Hello, I am Chase Millsap. I'm one of the directors of the film that you saw. So, thank you. My brother is also one of them, but we're still recovering from that. Little brother and older brother. No, I'm just kidding. He wasn't able to be here tonight. But I am a proud 2016 graduate of MPP here at Price. Yep. And I am proof that they will invite you back even if you barely passed your econ test. So it can happen. So I want to say thank you to Price for having us here. And also, just show of hands, Price students, how many of you are in here? Okay, we got a couple. I just want to say thank you, specifically to you guys for coming, because I know how much work you have to do. So taking an hour and a half and this to do that is a big deal. So thank you guys for coming. And we're going to talk some policy. So I want to introduce you to our experts here, one of whom is Sharon Schindel, producer on the film, also a lawyer, and she'll describe to you about that, of who's been associated with addiction and pain for a very, very long time. And Rosalie Pacula, one of the professors here at Price, who has also studied and researched addiction from the beginning to now. So you've got a wealth of experience on this. So we'll dig in that. But I wanted to just quickly, Sharon, is there anything you want to add as well?
Just that all our producers are in the same room together, so I'm one of five, and I just want to introduce the others in the room. You may know him from this film, Dale King. And Miley Gherkin Millsap. And J. David Harden. That's all.
Okay. And Rosalie?
Well, I have nothing really good to add from that, but I just want to say that I am very privileged to be here in a room where you see community really connecting and caring. Addiction has been with us for a very long time. It's been killing us at a much higher rate the last 10 years than previously, but it's been a long problem with a lot of social stigma, and it takes big action like this to really make change. So thank you for including me.
Perfect. Well, let's start with that. So let's ask the big question of how did we get here today in addiction and opioids and all the other things that have come through this? And I guess the big question from a policy perspective is, what are some of the things that you saw in the film that resonated to policies that maybe haven't worked or didn't work as intended, or maybe some barriers that you saw that are being lived out on the screen?
How did we get here? The opioid crisis. I think many of you have heard this in the news. I am an economist by training, have been studying markets for addictive goods for 30 some odd years. We got here because of a supply problem, a promotion, marketing, and campaign to increase demand for something that can and should be used as medicine, but was promoted for reasons beyond its appropriate use because of profit. And it was effective because it was done within a secure system, the healthcare system, where there's a lot of trust. It's targeted towards doctors, where we have a lot of faith in our doctors, and a big group of individuals who never would have previously chosen an addictive good were brought in because they had a medical need, and they were told it's okay to take 30, 60, 90-day doses of an opioid. So we're here because of a problem with supply, which might shock a few of you who are used to hearing it as a demand problem. This mortality rate is not a demand problem. It's started supply in a legal market and then supply in illicit market, because as users of the medical product moved into the illicit market, there were shortages. How do you accommodate shortages? Well, you look for ways to fill in the gap because you can't necessarily produce more quickly. And there was a really cheap filler available in the illicit market, fentanyl. And it started as a filler for heroin and became a filler for everything. So what can we do about it? I think that it's really important to see some of the really successful strategies in the film, some of which were not due to policy by any means. In fact, you hear in the film about how people were coming into the ED department in need of treatment and there was no treatment available. And that was a policy shortfall. We have spent a lot of our efforts, I was giving a lecture today to some undergraduates, our efforts in fighting the opioid crisis. And in the first 10 to 12 years, it was all about supply reduction strategies on prescription opioids. We did not start investing in treatment until a good 10 years into the problem. And unfortunately, our treatment system is dilapidated. It's a historical artifact separate from medical system. Our doctors aren't trained, and you heard that in the film, needing to educate doctors about this condition so that they knew how to handle people when they presented themselves. If it wasn't part of their training, they don't know what to do. Unfortunately, in order to be able to be trained to prescribe a therapy, if it's not a behavioral therapy, they needed extra training and a DEA license and permissions to serve a certain number of patients until just this year. So they could prescribe the opioid that got people hooked, but they had to go through special training and special special hurdles to be able to prescribe a medication that can help keep somebody functioning enough that they are able to participate in a recovery effort like CrossFit. So those sort of hurdles abounded. And I think what was really amazing about this community is their willingness to tackle each and every one of them. And it wasn't necessarily through the traditional method. It was by building a sense of community and caring and getting those systems to change from inside, not from a policy change outside.
And you bring up a good point there, because there's a series of systematic gaps that the crisis and opioids specifically were able to exploit in a lot of ways. And so Sharon's not only one of the producers on the film, but is also, I'll brag on you a little bit, spent many years as a district attorney in Manhattan. And you've seen this from a totally different perspective, which is prosecuting people for being part of this. And what was really interesting for me learning about the film is that it was 100% legal when this started to sell opioids to people for almost really no proper diagnosis. Perfectly legal. It took almost a decade for the laws to change. So from your perspective, talk us through a little bit about how the legal system was either struggling to catch up or couldn't catch up, or how you dealt with that.
Yeah, I mean, it was a lifetime ago. But yeah, I was a foot soldier in the war on crime in New York City in the 90s. And I think it's pretty clear. It wasn't as clear then, but it's very clear now that that was an epic fail, right? Criminalizing addiction is and was no more effective in stemming the tide of the opioid now / fentanyl crisis than decriminalizing drug possession, which is what they're doing in Oregon. And I think that's because I feel like in this country, like we crave a quick fix, right? Like we want a magic bullet to some very complicated problems, and obviously there is none for something as complex as the opioid crisis, right? There is no one thing, right? Joining a gym is not the message of this film. Putting more and more stringent regulations for doctors so that they prescribe less OxyContin to their patients, that's not the one thing either. And I think if there's any message of this film is that, stepping outside of this paradigm of a quick fix and outside of a legal system is probably a little more effective. And I think like most complex problems that we are looking at today, it's going to take like a multidisciplinary approach. One that involves evidence-based practices. And certainly, if we know anything from what Dale has shown us, it's going to take real community buy-in and involvement.
This is a medical condition and a medical problem, but our healthcare system was not built and has not been sustained in a way to integrate it closely as a medical problem. And we triage it as a problem. There wasn't a billing code to do brief interventions and referrals to treatment. So doctors, they existed, they weren't turned on. It takes time to do a brief intervention. And if you're not gonna get reimbursed for your time with the patient, why are you gonna do the activity? So we can't identify patients early on in the process and get them to effective programming early when it's easier to start managing the disease. Like any disease, whether you're talking about diabetes or hypertension, the earlier you start getting them conditioned to treatment, and you need doctors on board, you need to reimburse the doctors, you need to make them aware to be doing this, and they need to know where to refer the patients to. As you were saying, it's not just about CrossFit, it's about getting the right health care. Mental health and substance abuse treatment has been done outside of the system and without the doctor supervising because payment reimbursement, because of historical artifact, because of stigma, because of lack of knowledge. And those factors didn't allow it to be treated there. And then all those other social justice problems fall on top of it. And it's not just addiction. Addiction is really important, but the addiction and mental health together is not easy to fix when you're not addressing any of the underlying problems. You're just gonna have the chronic relapse. Chronic relapse is very expensive to us as a healthcare system, but more expensive and more costly to the family and the community who invest in these individuals, and they relapse because this is a difficult disease to do, especially when you're not getting adequate treatment. So building the treatment facility as well as the infrastructure to support people who are going through it and support them in recovery is absolutely critical. That can't be done in a criminal justice system.
Well, and it's interesting you bring up that it's outside of addiction as well. I mean, at the end of it, I think one of the things we saw as the filmmakers is pain, right? It's just this overwhelming sense of pain that people are dealing with, whether it is the relapse, whether it's going through the addiction, whether it's economic pain. And one of the things that I think, you know, the gym does very well is to say, well, that's what we're going to use as a tool to get out of this, and flip that narrative around. And Sharon, I know you've lived with chronic pain for a very long time. I just want to get your sense of not only living it and going through it yourself, but what is it about some of our characters that you saw on screen that could be inspiration to others, or that could be an inspiration into better policies?
Yeah, I mean, certainly I would love to say that my experience as a chronic pain patient in America really helped inform the vision of this film, but that would be a total lie. What ended up happening really was that the people in and behind this film really guided me through, and my husband's here, what was easily the worst time of my life. It was the height of the pandemic. We were in pre-production. I was cutting what was to be a sizzle reel for this project, which wasn't yet a film. And I was diagnosed with a really rare and brutal chronic pain condition that when I Googled it that night is called the suicide disorder. And at the time, you had just shot a bunch of B-roll in Dale's gym, and every shot was of this huge, like, block letter, the gym motto on the wall. I don't know if you can see it in here. And it's a Henry Rollins quote that Dale has up there. And it says, pain is not my enemy, it's my call to greatness. And I just remember, like, trying Well, I tried to quit the film. I tried to quit the project because I was like, look, I'm just in so much fucking pain. Like, I can't do this. And you like tricked me into staying on. And so I am
Totally true.
I'm editing the footage, and every shot, all I can see is this frickin' thing. Pain is not my enemy. And I so wanted to believe it, you know? But at the time, like, it was my freaking enemy. Like, I would have done anything to stop the pain. Like, opioids, sure. Like, whatever, you know, black tar heroin. Like, I didn't. But that's the condition I was in. And I wanted that. I wanted to believe that I would get something out of this pain. And it took me a while. It took me like a year or so of, you know, working on this film, and it's like, I got it, you know? When I stopped fighting my physical chronic pain is when, and when I accepted it, is when I really kind of found meaning in my suffering and a call. Like, I'm gonna make this goddamn film, even though I'm in so much pain. And so I think, I mean, I knew there were so many intersections between chronic pain and the opioid crisis. Obviously, I think I've always known, and to your point, that we do have a chronic pain crisis in this country, right? And that has easily fueled the opioid crisis because modern medicine has not come up with a treatment for chronic pain in about 3,000 years.
And we don't provide insurance coverage for alternatives to
Oh,
pills.
right. No, it's just quick fix. Take this pill. So I knew that, but I guess what I learned during the film was really this universality of pain, and whether it's from depression or mental health struggles or addiction or physical pain, pain is so isolating. Like, you are just alone, and it's a dangerous place to be in your head. And I think what I've learned from, like, Sarah especially is like, hey, this pain is a universal experience, and we're not alone. And that, to me, is like, okay, so we're all trying to, like, make sense of this, and we're all trying to make sense and find meaning from hardship and struggle. And that, for me, is just really empowering. Like, I just, you know, Sarah gives me advice. Sarah Wilson gives me advice about, like, how to get through a bad day. And so I love that. And that's my wish for the film, really, is that someone in pain, whatever kind of pain, sees it and, you know, maybe get some hope that they can make some meaning or find some purpose in it.
Well, you said the last word really resonated with me was the hope aspect of this. And I mean, if you take just a step back, it seems like an insurmountable problem. And I know, Rosalie, you've studied this not only in the US, but I mean, just all policies across the globe. Why is it that we're talking about fitness and a small community in Ohio as a guiding post, or as a light of what's possible in other places?
So there's a couple of reasons, and the film speaks to it. You know, exercise done at high intensity will trigger a response in the brain that is helpful for a small, short amount of time in coping, and that's wonderful. But the idea of exercise to manage or support recovery has been tried in other locations. It's actually a very big strategy in Colorado with some of the alcohol recovery systems. However, it hasn't ignited and taken hold the way it has in Ohio, in part because it's not just about the fitness and dealing with the brain chemistry, which is, yes, that is vitally important. It's also that building of community, the friends at the gym, the connections at the gym that transition into jobs, even if you don't have housing, even if you have a criminal justice record, that someone will take a chance on you. Right now, those systems have been very separated in communities because they don't have the net that's bringing them together. They don't have the Billy and the Dale to pull it together and make that system available. Today in healthcare, we talk regularly about the social determinants of health and how the environment affects our health. Our ability to access transportation affects whether or not we can get good health care, or housing affects our ability to cope with any sort of medical condition. It's even more true for addiction and for mental health problems. In Europe, where they have more of a safety net, there's more opportunities to access housing, job training. It's built into their systems. You have a country like Portugal, which has completely decriminalized cannabis, cocaine, heroin. No more pathway through the criminal justice system. But that system is not legalization. There is no supply chain for those drugs allowed in Portugal. In fact, a conversation I had with the Minister of Health from Portugal, he's fighting cannabis legalization vehemently because their system right now is enough to support the users. When someone gets into trouble, say a traffic accident, impaired, or they overdose, that individual doesn't go to a court. They go to a panel of community health experts who assess in a conversation with the individual. There's a doctor, someone from the treatment community, and a social support person. Assess where that person is in their journey. What do they need? If treatment is effective, that community board, local community board, advises treatment for the individual. They can impose a civil penalty. You don't need jail and a criminal record to entice some people to go to treatment. If they assess that the person's not ready for treatment, they suggest education. They require a work record, other things. All these things we want for people to become engaged, that's what the community panels are doing in Portugal. This is not about legalize, leave them alone, let everybody be free and happy and independent. It's a community acknowledgement that this person is having difficulties that are making them disconnected from community, or maybe they're just having a good time and experimenting and they're not ready to do anything. That's what the community board is assessing. No judgment, just where's this person at? And what are the impacts of their behavior? Are they negative to the individual or other people? This community in Ohio has built that safety net of what does this person need? And they figured out how to get the people what they need. And it was done outside of a public health committee and outside of a jail, but within the community. So what's the special sauce in making these things work? It's not our approach to criminalizing or even forcing mandatory treatment on people, but meeting people where they're at, identifying what their real needs are, and helping enable them to get there, not judging them. And you can't adopt a policy that's going to change people's opinions about people who use drugs. And that's the problem.
So let's go on that for a second. So we put our policy hat on for a second, especially for those who may be watching later. And I do remember a few things. There's the 8 steps, the Bardax, remember that? I do remember plenty of white papers, which I've written a few of those. But I'm curious, and Sharon, I'll start with you, and then Rosalie, I want to hear your opinions. How do we change that idea? How do we open the policy window to at least get people to start thinking that, hey, there might be other options here to do this? How do we do that?
Okay, well, I think neuroscience has taught us that we are hardwired for story, right? And I think especially, if the last, election cycles have taught us anything, like facts, no matter how compelling they are, truth, no matter how rooted in science and reality it is, that does not change hearts and minds. Like that's not what's resonating at all. And so, we can talk about the national recidivism rate, right, which is 70% of offenders end up back in the criminal justice system 5 years later. We know jail and prison is a failed experiment in the United States. That's a fact.
And it's expensive.
And it's super expensive, right? Ineffective, expensive, and morally probably not the cleanest thing to do. But maybe through story, right? Maybe through story that resonates with people, instead of getting on a soapbox, we can just show, talk less, do more. That's what Dale's doing. I don't know. I mean, I think for us, that's maybe an easy answer because we're storytellers. But I do think it'll help. I also think there are pockets of this happening right now. There are very successful community or collaborative courts in this country. In California, in Orange County, there's a veteran treatment court. There's a DUI court. There is a drug court. Right. And what it does is the criminal justice system kind of is the leverage that brings them in.
The stick.
Right, it's the stick, not the carrot. But instead of being offered a prison sentence for a drug-related charge, you're given treatment, you're given job skills, you're given housing, you're given access to government agencies and benefits that can help you. And those are working, and those don't have a 70%, those courts don't have a 70% recidivism rate, right? Because we're not just bringing people into the criminal justice system, letting them spend 3 nights to sober out in jail, and then letting them go. We're giving them accountability, community, connection, and so I think telling those stories is also really important because we've kind of got it, but it just hasn't taken off.
Even with those success stories, though, like you mentioned, the recidivism relapse rate can still happen. It's less likely after a year, but it can still happen after a year. And you saw that in the film, the reaction of the community to Billy relapsing. The need to approach individuals who relapse with compassion instead of with judgment. When someone fails in their diet, they feel bad enough. They don't need us judging them. When someone fails on a test, they don't need judgment. It's this, why do we think that we need to judge others on their failures? We're all human, as they say. We need a community that can hold us accountable, but without judgment. You don't need judgment to have accountability.
Right, so that would not be family.
That
would not be family. So family is not the answer to the opioid crisis.
Well said.
That's my takeaway.
Well, I know we want to open it up, but I just want to ask the question to the audience. How many of you, show of hands, have known somebody that's gone through addiction, substance abuse, or has been affected by it? How many in this room? How many of you know somebody that has overdosed? How many of you know somebody that's passed away from overdose? I mean, I think it's safe to say that every one of us in this room has been touched in some way by this. So I want to open it up, and please, we have plenty of people in this room, but we'd love to hear questions, thoughts, feelings that may have come out from this. We'd love to hear from you, and we can respond to that. In the back.
What does the medical community think about Chinese medicine or Eastern medicine, holistic approach for substance abuse people? For example, there's something called cupping. Have you heard of it?
Yep.
Or, and they have like some
acupuncture,
and it deals with pain. Because I know someone very dear to me that's been through a car accident and is not an addict, didn't take any of the painkillers, and does a lot of Chinese medicine, a lot of acupuncture, and was able to avoid opioids to be able to live their daily life.
That story is my story as well. I was in a severe car crash here on the 10 and was so close to turning to opioids after being on my back for 3 weeks. And it was my neighbor who kept saying, just try, actually, it was not physical therapy. No, it wasn't.
Chiropractic.
Chiropractic. Thank you. I'm tired. I've been up a lot today. So it was chiropractic care. And that saved me from going to opioids. It didn't work right away. It took me a week and a half, 2 weeks before I started relieving pain. But when you go to physical therapy and are doing physical therapy, it doesn't affect you right away either. So your question is this question of Western medicine versus Eastern medicine. Some of that is what needs to be present in our training of physicians in medical school and insurance coverage for the alternative forms of medication. I can tell you we have seen substantial change in Medicaid and Medicare and in the private commercial insurance for coverage for these alternative forms of pain management in the last 8 years. It took killing 60,000 people a year for them to do that, though.
Yeah, and to your point and to your question, it became very clear to me as someone living with chronic pain that my insurance company, not my doctor, dictates my care.
Yeah.
So I think it's like 10 cents a pill, for an oxy, but they're covering $30 for a $100 PT session. $20. Acupuncture is not cheap, and it's it is evidence-based. We know not just anecdotally, we know these things work.
The evidence is different than the evidence for the pills, though, I have to say. So I've sat on NIH scientific review committees, and there is some evidence for acupuncture and some evidence for chiropractic care. Those studies haven't been done in the way medicine traditionally does, the double-blinded random control trial, because if you're getting acupuncture, you know it. Right?
Right.
So the level of evidence is deemed not as high as what you can do with a pill, which is part of the problem. But our research methods are improving to evaluate things in a real-world setting.
How about the evidence of damage of opioids as it relates to?
Well, that's why we now have the insurance companies changing their minds.
They should add the damage part.
I don't even know where to begin, because actually watching this documentary was so profoundly depressing, I think. And Dale, I mean, kudos to you. What you did is amazing. And what you're continuing to do, you're calling to do this. But it's like a lightning strike. You know what I mean? It should not require one man coming back to his hometown and having an epiphany and having the wherewithal, the mettle, the backbone, the energy to do this. Because this is like a miracle that this all happened in your town. You happen to be that guy to do that. That's amazing. And I'm just saying, everything I'm hearing about, so this is the approach that we need to take, and we need to, focus on this other stuff. We have to change. I mean, it's so big. We have to change American culture. Yes. Because again, everything that everybody's saying here, they'll just drag that one word out. They're like, that's socialism. And I mean, it's like the pinnacle of all this stuff, because you mentioned like Europe or whatever. You go to Copenhagen or whatever, and I mean people have to give a shit enough or have to buy into it enough where they're gonna be willing to be taxed more or to care more. So again, for me, it's so profoundly depressing that we live in this society that is so opposed to seemingly common sense in evidence-based proof. Again, to the quick fix thing, we would rather hire 1,000 more police officers and make it easier to beat the shit out of somebody and build another jail, because that's tough. I mean, we have this like manhood issue. And I know it's broader than that, but I think a lot of what's dictating these policies and this sort of like mindset is this kind of like weird masculinity problem, I think, that we have in this country. This sort of like...
Trust in free markets and free will is what it is. We have this unconditional belief, and I am a PhD in economics, trust in people's search for their own self-interests, and in businesses, profit incentive, and everything will work out. But even an economist knows that only works under certain conditions. And those conditions do not apply when you have imperfect information and barriers of entry into markets and asymmetric information. There's just a number of reasons why when we talk about addictive products that we still let businesses sell as if they are cheesecake. Cheesecake in excess doses is really bad for you, but most of us know when to stop.
That's why we CrossFit. I'm going to add on to that. So we filmed this over 4 years. So Dale had a microphone on him for about 4 years, so I'm letting him have the night off. But I can honestly tell you that we had no idea what was going to happen. We did not know that the film was going to end up like this. I mean, we originally thought it was going to be a TV show, right? And it became what it is today because we kind of went with the same approach that Dale has taken towards rebuilding the community, and it's one day at a time, one person at a time, one situation at a time. Because if you start thinking about the weight of this, it's just so overwhelming that it's like, how do you even try to get out of it? You just start with something right in front of you in your hometown and what you can control. And in a lot of ways, even on the days that it was very hard to film, we had no idea what we were doing, it was like, we're at least gonna go in and get a workout today. That's what we're gonna, that's the basis of it. And then from there, you start to see that things build. So there really is, in a lot of ways, it is one step at a time. And I do hear you, because it's, if you can get that in one community, another community tells another, and the spoiler alert that hasn't come out from the film, and Dale may be able to talk about this later too, is, there's been already, you see in the film, the city of Chicago, there's been at least a dozen, probably more, that have already reached out and said, we want to do this in our town. How do we do this?
And now there's money to support it, which wasn't true before.
I realize watching this, we think about this as such a uniquely American problem, and that's just, kind of built in. And I realize I don't actually know, what other countries might be struggling with a similar problem. Are you aware, are there countries that are prescribing opioids at the same level but not seeing the same level of death or addiction, or are they just not prescribing, or is this more rampant and not uniquely American?
We are now seeing a spread of the opioid overprescribing in other countries led by the international arm of Purdue Pharma. They are delayed, and they were much later than in the US, because in the US we have a policy that allows pharmaceutical companies to market directly to physicians and inform physicians about their drugs, because who's better to educate a physician than the company that develops it? In other countries that is not allowed. They have an independent agency that all pharmaceutical companies have to present the benefits of their product and the side effects, and that independent organization is what educates doctors about both the benefits and the risks. So you don't have, typically, a company pushing. However, with the rising obesity epidemic, which has been happening globally, there is an increase in chronic pain, and you do see more prescribing of opioids starting to occur in Europe, but it is nowhere near. And Canada's having a raging opioid crisis right now, but it's not driven strictly by pharmaceuticals. It's driven because of fentanyl now seeping into everything. So it hasn't grown out of the medical market the way it did in the US. That is uniquely American because of the policies that we unfortunately still have in place. One of the things I try to talk to policymakers about is the opioid crisis isn't an old story and we don't need to worry about it because the prescription drug problem was back in the 2000s. How many of you know someone taking Adderall? How many of you know how much that goes for on the illicit market and is the drug of choice of most college students and graduate students, because it will help you focus and pass a test really, really well. And doctors have been prescribing it more. And we now are experiencing shortage, so even patients who need Adderall can't get it because it's being overprescribed off-label. We can change these policies, we can change these holes. Medicine should be available for patients, and it should be affordable for patients. Off-label prescribing and generalization of allowing pharmaceutical companies directly to market their products to physicians, we started putting that under the light, the street light, in the sense that since 2013, the Sunshine Act, now pharmaceutical companies have to report what they're doing in promotion. That's not actually stopping them. Europe and the rest of the world is much more cautious. Why? Because the government is paying for the healthcare costs. So they pay the cost when patients are using and develop chronic problems because of inappropriate healthcare. So they have an incentive to be more cautious. But because of that, we have more pharmaceutical innovation in the US than in these other countries because they make more profit doing it here. So there's benefits and costs. But yes, there's a growing overdose crisis. It's not as bad as the US by any means.
Hi, I have less of a policy question, but first I wanted to thank you guys for being here. And Dale, thank you for all your community work. So I'm actually from Cincinnati, Ohio, so it's really cool to see something local to my state. And the documentary was powerful, it was sad, it was everything. So my question was, how did you guys get connected to Dale, and what made you pick Portsmouth as the location for the film, and how did you learn about it?
Oh, I knew somebody was going to answer that. So my wife, Miley, in the back. I think, there is a picture. Miley and Dale went to prom in the same group 20 years ago, 25 years ago. So it's a small town story. But what I think it came to is I was living here. We were both living here in LA. And I think we immediately knew that there was just something different happening in Portsmouth. And you could see it. Because when Dale talks about it in the film of coming back from a war zone into a war zone, I saw it as someone that was coming for holidays from here. I was going back for a vacation. And I'm looking at Miley and I'm saying, why did you bring me back here? Like, this is really dangerous. And then every trip, it kind of got a little better. And I just thought, well, something's happening here. And then everyone kind of said, hey, you got to go check out this guy, and he's got a gym. And that's truthfully what started it for me. And then as we started filming, and I fell in love with Dale's mom because she's just hilarious, and so that we wanted to keep following her. So it really started at the ground level and came up. And I think one of the challenges, but it found its own ending, was that we wanted to be able to say that that Portsmouth in and of itself is unique. But there's hundreds and thousands of small towns across America that have similar stuff. And if it can be done there, it can be done in other places.
Imagine channeling some of our veterans in each location, because they, as Dale demonstrated, they've been trained on how to execute. They know what to do. They just need a team to do it. And we have veterans dying for a purpose here in the US because they've sacrificed their lives abroad and come home, and everyone's doing their thing and they don't know their purpose here. We have a lot of problems they can help us fix. And we have to be mindful that it's not just opioids that are addictive. Your comment about wanting to get out because we want people to be aware of fentanyl. I want people to be aware about cannabis and psilocybin. Yes. Are those two products that can be used for medicinal purposes? Yes, they can. But when you legalize and don't put any guardrails in place and allow everybody to supply freely, and people make money by making more sales, you see the potency of a plant that's been around for centuries The average potency going from 13% THC, which is how this plant has existed for centuries, to products being produced by this industry that have 90% THC. That is the average THC of a vape liquid and concentrate sold here in California. Wow. It's harmless. It's a wellness product. It's a plant. No, it's industry.
It's
Capitalizing
Yes, it is constant.
on the one ingredient in the plant that will hook people in. Does that mean cannabis is bad? No. Does that mean we need to put public health policies in place so that we don't have people are dying from cannabis overdoses today? And that's not because that plant was dangerous. It's because 90% THC taken in our body when you're not used to it, you're naive, affects your body like a shock that would be as bad. I'm not saying everybody, but it can create the heart attack, it can create the psychosis, it can create the suicide ideation that the plant didn't generate by itself. And we have to be mindful of that. Legalizing a product and making it available so that it's not illicit and impure, and we want to have people buy things in a store is a good idea. But let's make sure we know that what we're selling in the store isn't going to have long-term health implications and harm. And if it's addictive, their biggest sales are going to be on the heavy users. And so they know how to market to them. Capitalism, unfortunately.
I would just say there's one anecdote, and I love that you're working with the children on this one, because that is such a critical area. It's such a start. One of the things you might have missed it if you weren't paying attention, but they've created a children's museum there in Portsmouth, and one of my favorite parts of that museum is they have a whole wall dedicated to the chemicals and how your brain responds to them.
Oh, that's great.
And they start teaching that at a very young age. So what we had to learn the hard way, right, at 40 of like, I don't even know how this stuff works, they're starting to at least have the conversation at that level. So I think that's one way. So I just want to thank everybody for coming tonight and thank our wonderful panelists. Yes. What's that?
Where can we buy the film?
It is on iTunes and Amazon currently. You can get it. Tell your friends. Small Town Strong. And we'll hang out here for a minute if you have any other questions. But thank you for coming.